Okay, great. Thank you for the invitation, and thanks for putting this session together. So I'm going to zoom out a little bit from what Dr. Flaxman was talking about, moving from sort of the individual level to sort of questions about the contributions of different causes to overall disease burden. So, the questions that we might want to answer come of the form like, what is the burden of death caused by X? And X could be COVID, it could be pandemic flu, it could be a hurricane, some sort of disruption. And then we might want to sort of ask in another way, what is the effect of that event, whether it's a pandemic or natural disaster, on specific outcomes like cardiovascular mortality or cancer mortality? And as Dr. Flaxman was saying, cause of death statistics can be difficult to rely on. So, we have sort of this typical chain of events where maybe somebody is undergoing treatment for cancer, which increases their risk for COVID infection, which then triggers a heart attack, which causes them to die. And it's really an art as to sort of how you assign the cause of death in these situations where, um, and there are, good guidelines out there for sort of how you do this assignment, but there's still an element of judgment that comes into this. Um, so you have to sort of think about what's the underlying cause of death here. So it should be recorded in this situation probably as the COVID infection, maybe it's the cancer. Um, but then, what if the person was never tested for COVID? In that case, what happens and what gets assigned as the cause of death? Or if the cancer treatment wasn't recorded in the right place, or if the databases weren't linked appropriately. So there can be a lot of issues. And this has been recognized for a long time. So, there's a quote in this paper about the challenges in attributing causes of death following cancer treatment, just saying how the cause of death assignment is inherently subjective, and we rely on judgments made by numerous individuals, or maybe now by ChatGPT, when completing the death certificate. We saw this come up as an issue a lot during the COVID pandemic, especially early on, when there was a lot of question about the reliability of the death toll, the reported death toll due to COVID. There is a lot of assumption that the reported deaths were an undercount. There was some suggestion on the other side that it was potentially an overcount. But in general, a lot of mistrust of the official cause of death statistics, and an understanding that they weren't especially accurate. And this is sort of a issue that's been recognized with infectious diseases for a long time. And typically for infectious causes, what gets reported as being caused by influenza or COVID or RSV or whatever it is represents an undercount. And an important reason for that is that our testing is incomplete and imperfect. So, not everybody by a long shot gets tested for all the different viruses and bacteria that could be causing particular death. And we could see this during the 2009 flu pandemic, where only about, 1/7 of the deaths caused by flu were thought to be attributed to flu on official statistics. But we could also see that, during a typical influenza season as well. So these charts here are from a paper from quite a while ago now, just showing time series of deaths due to cancer and heart disease and cardiovascular disease, diabetes, um, pneumonia and influenza. And basically what you see is for all these different causes, you see spikes in the reported deaths that coincide with spikes in influenza activity, suggesting that, what we're attributing to cancer or to cardiovascular disease has some infectious trigger. The numbers can also get skewed in the other direction. There was concern about this during COVID when we're using really sensitive molecular tests like PCR, where a person can be positive for a very long time. You can get sort of incidental detections of the virus. So, somebody dies in a car crash and their there's a virus detected in the individual, which obviously isn't related to the cause of death. So we're in the situation where we can't necessarily rely on the cause-specific coding of the deaths, although it sounds like Dr. Flaxman is going to help us solve that problem, hopefully, or improve our situation. But we can look at changes in all-cause mortality, and that can give us an indication of what's happening when there's a discrete event that happens. So when we have a disruption that's sort of intense and for a relatively short duration, like a pandemic or like a hurricane or a heat wave, we can see the effect of that event on all-cause death rates. And this is usually done using either time series models or spatiotemporal models to define what we expect the normal rate of death to be in a specific population at a specific time. And then we look for deviations from this. So this is data from the EuroMOMO project, where we have the observed deaths in blue. And then there's a statistical model that's used to establish the expected deaths, which gives us that sort of sinusoidal seasonal pattern. And we can see the difference between those observed deaths and the seasonal baseline give us excess deaths, and we can see how those coincide with different infectious periods. So to do this type of analysis, there are sort of three things you need. You need sort of the complete count of the number of deaths, regardless of the cause. You just want to know how many people died in a specific location at a specific time point. And you need that data for several years so that you can establish what a normal pattern of deaths looks like. And then we have a statistical model that we use to try to estimate typical seasonal variation and trends in the data that we can use to compare going forward. So for the first piece, we need to basically get a count for the total deaths in the population. And there are a number of ways we can do that. Ideally, we'd have good vital statistics that captures 100% of the deaths in the population. So that's our best case scenario if it's available. That's often not available in many parts of the world, as we saw in some of the maps that Dr. Flaxman was showing. So you can do things like rely on regular household surveys in a health surveillance system where you go around and are regularly asking people how many people were born and how many people died in a household, which gives you some sense of the number of deaths and the characteristics of those deaths. We can also rely on indirect evidence. This is being done more and more recently using things like satellite imagery. So this is an example of a study that was done looking at the burden of COVID in Somalia, using satellite imagery to track sort of the digging of new graves in a graveyard. And we can also use things like news reports to get some sense for the burden of death in different populations. So once we have this information, we can feed it into a statistical model where I'm not going to go into the details of this, but basically it's effectively a regression model where we have the number of deaths as a function of seasonal variation, which gives us those nice sort of sinusoidal curves that capture sort of typical seasonal variation. We might have a time trend in there to adjust for sort of longer term changes in mortality. And if we're doing this in real time, we might try to adjust for reporting delays or incomplete deaths in the more recent months. So just as an example of this type of analysis, this is looking at all-cause deaths in the United States from 2014 to 2022. And we have a seasonal baseline here, which is shown in green. So that's your expected number of deaths. And then the observed number of deaths is shown in black. So you can see in the pre-pandemic period before that red line, basically the observed and expected deaths are pretty closely matched. And then as you get to the pandemic period, you see those lines separating. So that gives us our excess deaths, the difference between the black line and the green line. And we can see that if we look at different states in the US, we see different patterns. So New York City or New York State here shows a very sharp spike in March 2020, coinciding with the first wave of the pandemic, which hit New York very hard, followed by subsequent waves. If you look at Florida and California, you see different patterns that reflect the sort of intensity of the epidemics in those states at different time points. So how do we know that these are valid? and that this represents COVID deaths and not some other unrelated pattern. We can look at infection rates in the different states based on serological surveys. We can get estimates for how many people were infected with COVID. And in fact, we see that where we see more excess deaths, we see sort of higher infection rates in different states in the country. We can also do this type of analysis looking at specific cause of death categories. So this is based on the underlying cause of death that's listed on the death certificate. So we can look at heart disease. We again see spikes, some of which coincide with COVID waves, cerebrovascular disease, cancer. We don't really see much of a deviation from the expected values. And then external causes, which is a big grab bag category that includes car crashes, overdoses, and stuff like that. So if we zoom in on that category, we can again see different patterns for the different causes of death. So we can see increases in motor vehicle accidents, increases in drug overdoses, and increases in accidents and injuries. So one thing to notice is that the patterns of the excess deaths between these different categories differ in terms of sort of the intensity and timing of when we're seeing those increases. And that provides some information about what might be causing those different increases. So we can then sort of take this a step further and use statistical models to try to link those excess deaths, so those increases above the baseline, to specific causes. So we can bring in other information about viral epidemic intensity at different time points, other events that might be happening, lockdown intensity, healthcare capacity at different points. We can get sort of good individual level cause of death data from whatever sources we can. That might come from vital statistics, verbal autopsy, and so forth. And then the overall cause of death data, the total number of deaths. We can put this into a statistical model to see what factors best explain the patterns that we see in excess deaths. So when we do this in the US and we look at those underlying cause of death categories, we can see overall for all-cause deaths that 84% of the all-cause deaths that we see in the US during this time period could directly be linked to a COVID infection. So when we see a spike in COVID, we see a spike in all-cause mortality. And we see similar patterns for Alzheimer's, diabetes, heart disease, where the vast majority of those excess deaths in those categories could directly be linked to surges in COVID, suggesting a link to COVID, even though Alzheimer's or diabetes or heart disease was listed as the underlying cause. If you look at cerebrovascular diseases and external causes, you see a very different pattern, though. Very little of the cerebrovascular disease excess could be attributed to COVID directly, and none of the excess in external causes could be linked to COVID directly. These were more closely correlated with things like healthcare capacity and the stringency of lockdowns. So these methods are useful when we have a discrete short-term disruption to an otherwise stable baseline or stable pattern in deaths. It might be a seasonal variation or stable trend, but it's generally a predictable pattern. So things like natural disasters, introduction of a new pathogen, or introduction of a new variant into the population can be used with this type of approach. If we're thinking about sort of a typical season, and we want to understand, the contribution of different causes, we can use a related idea to try to sort of tease out the contribution of different causes to the burden of death or disease. So in this case, we might have a time series of respiratory disease deaths overall, or hospitalizations. And then we might have viral specific data from another source. So we might have viral testing data from a hospital or from a surveillance system or from verbal autopsy. And we have a statistical model then that takes and ingests information on the time trends and seasonality and patterns of all these different respiratory viruses. We adjust for seasonality, we adjust for trends in the model. We put this into a statistical model that allows us to sort of pull that signal apart and say, how much of the variation do we think is due to flu? How much is due to COVID? How much is due to RSV? And how much is due to sort of unexplained seasonal variation? So this is just an example of an analysis that we did using hospitalization data, but you could do the same thing for deaths, where we basically take the burden of pneumonia in young children and we try to break it down into its component parts. So using this type of model, we're able to estimate for kids under 1. The vast majority of the cases were caused by respiratory syncytial virus, with some contribution from flu and human metapneumovirus and paraflu, and then some cases that we just couldn't attribute to a specific virus and might have another cause, which is shown in gray at the bottom. So just sort of picking up on the thread from Dr. Flaxman's talk, where can we use AI and machine learning to sort of improve this process? So, I think the stuff that we heard about in the last talk is really exciting for improving verbal autopsy. I think these types of methods are already being used also for improving cause of death assignment in using sort of traditional death certificate data and administrative data as well. There's been some promising results that suggest that you can get sort of better cause of death statistics on the individual level. And then in terms of the all-cause death side of things, these models can really help us to, better use things like satellite imagery, movement data, and really to sort of fill in the gaps on those maps where we really don't have a lot of data by helping us to impute across different geographies. So hopefully by combining sort of improved individual level cause of death data, where we're never going to get to 100% in terms of assigning the causes of death, but hopefully we can do better. And combining that with sort of innovative methods for getting sort of the all-cause death data, we can help to fill in some of those gaps that we heard about in the last talk. So just in conclusion, relying on the reported cause of death statistics often has limitations. These types of excess death approaches can help us to fill in the gaps and quantify the effects from sort of discrete disruptions of various causes. And hopefully some of these new computational approaches can help us to improve the quality of the inputs that we use for these analyses. And just like to thank all the folks that we've worked with on this topic. Thank you.